Aldous.
Thank you very much, Mr Deputy Speaker. There has been an underlying problem with NHS dentistry in the Lowestoft and Waveney area for a long time, with dentists retiring, leading to resources and dental capacity being taken away from the area, notwithstanding the need and demand for NHS dentistry. And many, but not all of the remaining practices, have difficulties in recruiting and then retaining dentists. This situation has been exacerbated by a lack of funding, with net government spending on general dental practice reduced by a third over the past decade. Mr Deputy Speaker, in recent months the situation has reached crisis point, partly due to COVID, but primarily due to retirement of 2 NHS dentist practices in Lowestoft and the closure of the My Dentist practice at Leiston in the constituency of my right honourable friend, the member for Suffolk Coastal. The latter was due to the difficulties that they were having in recruiting dentists to work in the area. Mr Deputy Speaker, this is a national crisis. Official figures in March 2020 showed that 26% of new patients could not get access to an NHS dentist. The situation has worsened during COVID, with over 20 million NHS dental appointments nationally lost since the start of the pandemic. As has been reported today by the British Dental Association members survey, reveals that almost half the respondents intend to stop working in NHS dentistry in the next 12 months, and 2/3 estimate that they will not meet the new 60% activity target that they have been set. This is the worst survey that the BDA have ever carried out, and urgent action is required to stop dentists leaving the NHS in their droves. The situation is worse in Waveney. Community dental services, an employee-led social enterprise, have recently opened a new dental clinic in the old Magistrates' Court in Lowestoft. This investment is greatly welcomed, though CDS highlight the challenges that they are facing in the area. They are concerned about the lack of access to NHS dental services. Lowestoft and Waveney is an area of high need for dental services, yet there is a serious lack of provision which has been exacerbated by the backlog caused by COVID and, as I've mentioned, the retirement of well-established local general practitioners. The perceived remote location of the Waveney area and distance from all of the existing centres of dental training make recruitment difficult. CDS emphasised the need for a focus on prevention, particularly among children. The treatment of children under general anaesthetic for the removal of teeth, which cannot be saved, is the highest cause of admittance to hospital for general anaesthetic treatment in England and Wales. CDS advised that the reduction in local authority funding to support targeted or universal prevention, and Mr Deputy Speaker, I'm not attacking local authorities for this, has had a significant impact on the Waveney population due to reduced oral health improvement services. This limits CDS's ability to reach out to all the people who need their services. The impact on young people needs particular focus. In Suffolk, the proportion of children who saw an NHS dentist fell by half due to the pandemic. 60% in 2019 compared to just 31% in 2020. This translates to 43,000 local children missing out on their dental appointments compared to the year before. CDS, who are a paediatric dental specialists, have a high number of referrals from other practices of children with multiple decayed teeth which require complex treatment, quite often under general anaesthetic. The lack of general dental services locally makes safe discharge difficult, if not impossible, thereby creating further pressure on services. This has a devastating impact on children's life chances and could well prevent them from achieving the best start in life. COVID has made the situation worse. The interruption of routine dental care and the subsequent reduction in patient appointments has created a backlog of patients. The pandemic has also meant that the cancellation of and significant interruption to the dental general anaesthetic lists at the James Paget Hospital at Galston in the constituency of my right honourable friend, the member for Great Yarmouth, that causes greater problems. So this will recommence on the 1st of June, and the backlog of patients needing urgent care is substantial. This increases the pressure on dental practices who have responsibilities for their patients' dental care. It should also be pointed out that there has been no consultant orthodontist at the James Paget since mid-2020, resulting in patients having to travel further for care, and for children, this disrupts their education. I'm receiving approximately 10 emails a week from constituents, many of whom are in agony, who are looking for an NHS dentist. Some will go private, but for many who are on relatively low wages, this is an option which is not open to them and which they cannot afford. One constituent has been quoted £2,400 for a new front tooth and £2,000 for a bridge repair. Others who are in need of urgent attention, as I've mentioned, they go to the A&E at the James Paget in Galston. There, all that the exasperated consultants can do is to prescribe them antibiotics and painkillers. This, Mr. Deputy Speaker, is completely unacceptable. Another constituent has had a new denture fitted in 2019, which needed adjusting as it made his mouth sore and had a poor bite. He had no option but to use his old dentures, which were worn down and had a tooth missing. And he has only just seen a dentist and is now awaiting the new dentures. These are just a few cases which highlight the agonies that many people are going through. Andy Jacob, the Chief Executive of Healthwatch Suffolk, summarises the situation well. He says, "We are living through a dental disaster, with little or no clear sign of when these problems will ease. The latest review by Healthwatch England strongly supports our own local view that there is a huge inequality in the availability of NHS dental care amongst our population. This includes that some people have waited unreasonable lengths of time to get an NHS dentist appointment, while being told private appointments were available within a week. Here in Suffolk," he says, "we are being inundated by feedback on a daily basis from those struggling to access these services. One individual revealed to Healthwatch Suffolk that they required urgent hospital attention after overdosing on painkillers to combat their symptoms, while another told us that they couldn't find a dentist to treat a tooth which had reached a point where it was decaying." Mr. Deputy Speaker, I'll give way to my honourable friend.
Thank you very much for giving way. I have to confess I have a slight self-interest in this, in that my father was the NHS dentist in Fakenham for 34 years. And the problems in North Norfolk with dentistry are absolutely terrible. Long waiting lists, people not being able to be seen, and the Healthwatch report in the last day or so absolutely corroborates this. It strikes me that the contracts are some of the root causes with this, and the disparity between the private sector and the public sector. What can we possibly do to try to get more people to join this profession? I have one case in North Norfolk where for over 10 years I have not had a newly recruited dentist want to come and work in a surgery.
I thank my honourable friend for that intervention. And the situation it is very bad in Waveney. It is also bad in other parts of East Anglia, not least North Norfolk, and also in the constituency of my honourable friend, the member for Peterborough as well. But it is particularly bad in East Anglia. One of the reasons being is that we are perhaps a little bit away from the centre of things, and it can be difficult to recruit people to work in the area. He is right that one of the solutions is to reform the existing contract, which dates from 2006, and I will come on to that now, Mr. Deputy Speaker, as I look at some of the short and long-term solutions that do now need to be instigated immediately. In the short term, I urge the Minister, my honourable friend and Suffolk colleague, to take the following actions. Firstly, to reduce the UDA, that is, units of dental activity targets. The previous 20% target was appropriate, but the new 45% target is wholly unrealistic. Many practices will be forced to substantially reduce the number of emergency cases they provide and replace them with routine checkups, which are less time-consuming, resulting in an even longer backlog of outstanding emergency and urgent care cases. Money which is at present clawed back by the NHS, if dentists do not deliver UDAs, must be reinvested in the Waveney area. Dentists under-delivering does not indicate low local demand, and any clawback should be reinvested into local dental services, not transferred to other areas. This is a situation which is particularly prevalent in East Anglia. In 2019-2020, 9.1% of total contract value was clawed back in the region, compared to 4.8% nationally across England. Mr. Deputy Speaker, I have to confess that I do not completely understand the opaque world of UDAs. But what I do know is that this system is short-changing my constituents, many of whom are in agony, and for children there could well be lifelong consequences. There is an NHS dentistry practice in the Waveney and Norfolk area who want to take on more patients, but are not able to do so as the UDAs are not available. John Plummer and Associates are a privately owned family dental practice with 10 NHS practices in Norfolk and Waveney. As NHS dental practices in the Lowestoft area have closed in recent years, dentists from these practices have joined John Plummer, and naturally their patients would like to follow them. However, as there are now no more UDAs available, they've been unable to treat them, as they will not be able to provide adequate treatment for their regular patients. These UDAs are then lost to the Waveney area forever. So much more NHS dentistry could be provided in the Waveney area if more NHS dentistry was allowed. John Plummer and Associates will open a walk-in emergency NHS dental service, but they're not able to do so, as they're not allowed to do any more NHS work. There is a continuing problem with COVID, Mr. Deputy Speaker, which is limiting the number of people that dentists can see each day. This can be eased by installing high-capacity ventilators in dental surgeries. This will reduce the period in between appointments in which the rooms are cleaned, but which most practices cannot afford. I recognise that there is quite a bit of devil in the detail, but I would urge the government can directly increase access to NHS dentistry by providing capital funding for this equipment, as the devolved administrations in Wales and Northern Ireland plan to do. In the long term, root and branch reforms need to be instigated immediately. There is a need to get more NHS dentists practising in the area. The Association of Dental Groups have put forward a 6-point plan to achieve this. Firstly, increasing the number of training places. Earlier this month, Health Watch Norfolk called for a dental school to be set up. Based in Norwich, this will be able to serve the Waveney area, and indeed the constituency of my honourable friend from North Norfolk. As quickly as possible, the government must instigate a recruitment drive, increasing the number of UK dentistry training places and introducing incentives for dentists to relocate to areas such as Suffolk and Norfolk. Secondly, EU-trained dentists should be recognised. Their role is vital. There must be continued access to NHS dentistry for EU-trained professionals, thereby preventing further shortfalls arising. Thirdly, overseas qualifications should also be recognised. The General Dental Council's recognition of dental qualifications should be automatically extended to approved dental schools outside the European Economic Area, ensuring a smooth process for suitably qualified dentists to work in the UK, notably from countries such as India. This should also include the doubling of places available under the overseas registration examinations. Fourthly, the complex and lengthy process to complete the performer list validation examinations, known as PLVE, for overseas dentists should be speeded up, simplified and harmonised right across the country, with additional measures being introduced to ensure that the process takes no longer than 8 weeks. Fifthly, whole dentistry teams should be allowed to initiate treatments. Allied dental professionals are at present not able to open a course of treatment. This means that they cannot raise a claim for payment of work delivered, with many practices unable to fully utilise therapists as a result. To address this, whole teams should be allowed to initiate treatments. Their fifth and final point is that the government should create a new strategy to promote NHS workforce retention. They must reform the NHS contract, which is the major driver of dentists leaving NHS dentistry. A new contract focused on the oral health needs of patients and targeting improved access and preventative care should replace it. With regard to the forthcoming Health and Social Care Bill, with the commissioning of dentists set to move to integrated care systems, it is vital that dentists have a voice and are properly represented on ICSs. There is a worry that the possible pooling of budgets across primary care could lead to further cuts to NHS dentistry, and everything must be done to ensure that this does not happen. Fluoridation of water can play a key preventive role in oral health. It is very important that changes to the framework in which fluoridation schemes are carried out should be accompanied by the necessary capital funding for these schemes to be actually put in place. I anticipate that we shall consider this matter in more detail in the next few weeks when we debate the bill. Mr. Deputy Speaker, I now come to the new dental contract arrangements. As mentioned, underlying most of the problems of NHS dentistry is the fact that the current contract, which dates from 2006, is inadequate and now completely unfit for purpose. It must be replaced as quickly as possible. The BDA are looking for this to happen by April 2022 at the latest, and the new contract must break with the units of dental activity, must ensure that NHS dentistry is available to all those who need it, and must prioritise preventative care. Mr. Deputy Speaker, my honourable friend and Suffolk colleague is faced with a major task. From her perspective, it is unfortunate that the music has stopped on her watch. In summary, I believe there are 3 things we need to be doing. In the very near future, I would urge her to provide those practices, such as John Plummer and Associates, who will tackle the enormous backlog of work, with the resources to do so. We must end the cycle of retirements leading to funds being removed from the Waveney area, never to return. Secondly, we must tackle the growing scandal of children having to undergo major dental surgery. This requires much work in the short term in hospitals such as James Paget, but in the longer term, the introduction of major public awareness preventative initiatives is absolutely vital. And thirdly, the dysfunctional 2006 contract should be replaced as soon as possible. Thank you very much, Mr. Deputy.
Minister.
Thank you very much indeed, Mr. Deputy Speaker. I would like firstly to congratulate my friend and colleague from Suffolk, the Honourable Member for Waveney, on securing time for this important debate today, and also to my friend from North Norfolk, who, for the second time today, has spoken about the challenges of dentistry that we have. Now, as my honourable friend said, this is not a new problem. This was a problem and a challenge pre-COVID, and the pandemic has very definitely shone a light, and things have become much more challenging in the world of dental provision during the pandemic. Dentistry has been significantly impacted because of the risks associated with aerosol generating procedure that dentists do, and obviously the saliva that's generated when somebody is doing a procedure on your mouth. In response, dental practices have been required to wear full PPE to keep them, their teams and their patients safe. Public Health England are reviewing the current guidance on infection prevention and control, and that I am mentioning this because actually it goes to his point on fallow time. So the time between the dentist putting their instrument down, cleaning down their room, and the time that's then available before they see the next patient, because some of these things have been big constraints in trying to have a throughput or a rapid throughput of patients through the consulting room. So fallow time now is as low as 10 minutes in many cases. However, that does depend on material factors such as the ventilation and so on. I am talking to NHS England about the use and the ability to support dentist practices in putting ventilation in, but I would gently point out that what sounds very easy in a sentence in this place is very often quite challenging. Not always are the buildings owned by the dental practice concerned. In order to put the ventilation systems in, you have to take the rooms that are being used currently to deliver care out. So you have that combination of challenges as well. But it is very definitely both with some of the new research around ventilation, but also around lighting, things that we are constantly looking at to see how we can further support the profession. It's been an important step forward, though, to reduce the amount of time between seeing patients in order to facilitate more care for more patients. But we have taken the action we have because infection control sits at the very heart of what we have to do. And I stress that emphasis because with the variant of concern in some of our towns and cities around the country, we do have to be very mindful that we are looking for progress forward as to how we proceed with dentistry, and I agree with much of what he said about making sure that we're looking for opportunities, but we do have to be mindful of the fact we are yet not clear of this pandemic. So, and that does bring enormous constraints. The thresholds that have been set for dental practices since the start of the year have been based on data with what's achievable whilst complying with IPC. Now, my honourable friend alluded to the 45%, which actually was the level of dental activity that was placed on practices in Q4 of last year. Actually, it is now 60% and 80% through orthodontics. And this is the tension that we have in this whole area. 60% is still 40% lower than what we delivered in pre-COVID times. Obviously. The challenge is how you make sure that you are able to see the backlog, drive forward with looking after the most vulnerable and those that have the highest degree of need, and not lose ground that's gone before, whilst having the complexity, as he said, of retirements and contracts coming back and so on and so forth. It is not just a question, however defective the 2006 UDA contract is, it is not literally just a question of swapping the one for the other. However, the current thresholds are monitored on a monthly basis, and these new thresholds have been put in place for 6 months. Dental practice have been asked to deliver as much care as possible, prioritising urgent care, particularly for vulnerable groups, and then delay planned care and make sure that they are dealing on a needs basis with those with the most acute need. In addition to these activity thresholds, NHS England has also provided a flexible commissioning toolkit. And I'm very keen the profession are able to get real-world examples of what can help deliver based on the successes that have been led locally, and some of them have been led in our own particular area. The use of flexible commissioning is to convert units of dental activity, or UDAs as he referred to them, to convert them to activity that focuses on priority areas, such as improving access to urgent care or targeting high-risk patients, which was exactly what he was asking for in part of his speech, that we looked at doing that. We are already doing it. It provides good practice, and regional commissioners can implement it. I am very keen to make sure that it, however, is being used as much as it possibly can, and therefore I am having very frequent discussions with NHS England to make sure that we're monitoring the use of these measures. Now, as well as flexible commissioning, there is also support available to local NHS commissioners to put that capacity where we need it most. And in the east of England, NHS England has developed the Transformational dental strategy, the aim of which is to prioritise urgent care, prevention and inequalities. Because despite our efforts to increase services, we know, and it is true in my constituency as well, that patients are still experiencing acute difficulty in trying to find an NHS dentist. It has been a feature of both this morning's debate, however, and this afternoon's debate, that there is often private provision available, where NHS provision is not. The NHS England is charged with commissioning to need in an area and making sure that we commission to the need that is in the area is something that contract change, which I am very keen to see to be delivered by April 2022, addresses itself to. But it is highly complex. I have met with stakeholders both in the UK. People suggest the Welsh system is better. People have suggested the French system is better, some of the Scandinavian countries. And I have met with members of the dental profession from all of those places. And actually, nobody has a perfect system. So taking what is good about the various systems and ensuring that we can deliver in localities so that people can have access to care when they need it is where we are trying to get to, with a particular focus on prevention. Now, we have a web-based programme in the East called Service Provider, and this provides up-to-date information on dental services that are available. And patients experiencing difficulties are able to contact the NHS England's Customer Care Centre and call 111 for help in accessing emergency dental care. All NHS dental practices in the East of England have been asked to reserve at least one slot per day for urgent dental care to improve the capacity and, as my honourable friend said, allow greater access. In addition to that, we have not stood down the urgent dental centres, the 600 that we had across the country during the height of the pandemic. We have left those in place, and we have a network of those also across both Norfolk and Suffolk. But we know that information on NHS dentists is not always easy to access, and alongside increasing the access that we want to do for patients, it's also crucial to support NHS dental practices and the mixed practices and arguably private practices in order that we then start to have a more balanced approach. Because as my honourable friend mentioned, and the honourable member for North Norfolk, part of the challenge we have here is around retention. particularly in our area. And I note my honourable friend from Newquay, we have discussed at length that this problem is not unique to the east of England. It is also something that I have discussed with Cornish colleagues as well. Practices have continued to receive their full contract payments minus agreed deductions, providing that levels of activity are met. An exceptions process has also been put in place for practices who have been disproportionately impacted by the pandemic. It is wrong to say that we want anybody to not feel that they are supported to deliver what they can. We have also made PPE available free of charge through a dedicated portal, and as of a week ago, had delivered over 367 million items free to dentists, orthodontists and their teams. The pandemic, if it has done anything, continues to highlight that transformation in dentistry is necessary, particularly if we want to make sure that we drill down on oral health inequalities that exist across the country. I am meeting with the chair of Healthwatch tomorrow, and I'm sure we will be discussing access, amongst other things, to dentistry at some length. We need to develop a sustainable long-term approach to dentistry that is responsive to the population. It needs to provide high-quality, urgent treatment and then restorative care where clinically necessary. But it also must sit with prevention at its core. The majority of oral health failures are preventable. He spoke about children. There is nothing more upsetting than a child being in acute pain and having all their teeth removed. This is a broader problem, and the flexible commissioning, making sure that we're doing supervised toothbrushing, which is something that we can encourage local authorities to put in, but also that we are enabling parents to do their part and making sure that they can help their children learn good habits from right the early days. You know, you encourage your children to look after their teeth by rubbing their gums before their teeth even appear, making sure that they understand how important it is. In addition to this, any system that we design needs to improve patient access and oral health, offer value for money for the taxpayer, and be designed in conjunction with and attractive to the profession. NHSE are leading on dental contract reform work, but importantly, engaging with stakeholders, including the ADG that my honourable friend spoke about, and they will be looking at what changes can be made to dental contracts in the short term to offer some improvements and some relief and respite to everybody, whilst details of the next stage of reform will be agreed by April 2022. Making NHS dental contracts more attractive to the profession will help with vital recruitment and retention, and I know this is something that all my honourable friends in the Chamber, across rural and coastal areas in particular, will welcome. Health Education England's Advancing Dental Care programme has also been exploring opportunities for flexible dental training pathways and how we train our dental workforce to improve recruitment and retention. I am also very keen to make sure that we use the broader dental team as efficiently as we can, because there are many skills held by dental technicians, the dental nurses, the hygienists and so on, that particularly could be used in the prevention. But with another hat in my portfolio on, the obesity agenda, and making sure that we all look after ourselves a little bit better and have healthier lifestyles, everything we consume goes in through our mouths. Dentists are wonderfully placed, as are their teams, to help encourage us to have a healthier lifestyle and eat a little less sugar. We remain committed to prevention and improving oral health, and I'm pleased that the Honourable Member for Waveney supports, I think, in his asks, the direction that we are trying to go in by changing the UDAs, concentrating on making sure we've got the skill mix right, focusing on prevention, looking at retention. But as he said, it is a complex area. I am also having discussions with the GPC, because he spoke about recognising dentists who have trained overseas and making sure that once we are assured of standards education and so on, that things are a little bit simpler. Making sure that we can expand schemes subject to funding being secured and consulted on. I want to look at the expansion of fluoridated water. As he said, it is one of the simplest ways that we can improve oral health intervention, and we could significantly improve the health of children across the country. It's unacceptable in this day and age that young children have total dental clearances due to preventable tooth decay, and the ROI on fluoridation is very compelling, and there needs to be a renewed focus on the investment in prevention. We're committed to increasing dental access, both in the short term but the long term, so that we can ensure equality of access no matter where in the country a patient lives. But this is complex. We are working hard at it. We are working with the profession. But we all do need to double down on both prevention and making sure that we are all walking in the same direction to bring accessible oral healthcare to people.